I have been told by my GP that I have high blood pressure, but I have no symptoms. Should I take a medication for something that I won't feel the benefit? How significant is having high blood pressure to my health? Hi everyone, and welcome back to the Longevity Podcast. I'm Jess.
And I'm Lee.
And today we're going to be talking about hypertension, also known as high blood pressure. So as with all of our topics that we discuss on this podcast, it has a direct effect on your overall general health and longevity. So the reason why we've chosen hypertension is because it is one of the biggest risk factors for cardiovascular disease. And unlike other things like your sex or your age, it is also a modifiable risk factor. So that means that you can actually directly help yourself by changing things such as your lifestyle or taking some medication to basically help yourself. So it's probably best to start off with the definition of high blood pressure. So I don't know, Lee, do you want to start or do you want me to do it? Okay, so hypertension or high blood pressure is defined as a persistently raised arterial blood pressure. So blood pressure is basically the force that is exerted on your arteries, which are coming out of your heart. If you do have a higher blood pressure, like we said, you are at an increased risk of developing things such as a stroke or having a heart attack, amongst other things.
Now, to put into context, I'm going to go through the prevalence. So back in 2017, there was nearly 12 million adults in England that had hypertension, which was just over 1 in every 4 people. Now, going back to the first few questions where we said you can have it without having any symptoms, it's quite concerning really, which is why we're going to go on to how to measure it and what the numbers actually mean.
Yeah.
So do you want to go through how you take your blood pressure? Or do you want me to?
Yeah, you can. All
Okay.
I was going to say was obviously, like we did say, that you don't really tend to have any symptoms. So it's kind of like, well, how would I ever get diagnosed with blood pressure? So really, it's opportunistically that you're going to get checked for blood pressure. So as you do get older, if you are above 40, if you have other things like diabetes, you should be getting checked for it. So hopefully you will get picked up if you did have high blood pressure. But that was just a point that I just wanted to make, that, you know, it's probably something to bear in mind that if you do get older, if you have a family history of it, if you're overweight, you have other conditions such as type 2 diabetes, like I just mentioned, it might be worth just getting your blood pressure checked, and you can do that in your local community pharmacy.
Yeah, I mean, going through that, we've had a couple of family members who've tried to get the blood pressure taken in pharmacies, and because of the workload on them, it's just too busy to get it done. But yeah, like you said, unless you've got a pre-existing condition, it's normally every 5 years you're advised to get it checked. And in that time, you can develop a lot of complications from high blood pressure that we will go on to.
Yeah.
But if you were to take your own blood pressure at home, which is what we're sort of leading to, the main thing is to make sure that you've got the right size cuff.
Yeah, that is so important.
Because a lot of people get an undersized cuff and then the blood pressure's through the roof, and then they're going to the GP, A&E, which is understandable because if you put someone on that's too tight, it's going to come up with too high a reading. But once you've found the right size cuff, which you can go onto the British Heart Foundation and find out with your arm size, what you should be doing. Now, in an ideal world, this goes in a GP setting as well. You should ideally take 2 to 3 blood pressures, and you should take the first 2 from different arms to see if there is a higher reading. Now, if the top number is out by 15, you should always take it from the higher arm, because that's meant to be more symbolic of your cardiovascular risk going forward. Now, when you do take your blood pressure, you shouldn't have your legs crossed, arms folded, you shouldn't be speaking. And then if you're doing repeat examples, you should have it really, like I'd say a 2-minute rest between each one. Now, going on to the numbers, there are numerous stages of high blood pressure. The stage 1, 2, and then it goes into severe.
Yep.
But we're going to go into what they mean, and it depends on what setting you're in, whether that be in a GP surgery, your home. Yeah, do you want to go through the numbers?
Yeah, so first of all, I'll start off with then you being in a clinic. So that means if you're in a setting where you're in a GP practice or you're in a community pharmacy. So anything below 140/90, so 140 being your top number, 90 being the lower number, would mean that you were a normotensive, so that you've got a normal blood pressure and that you don't need any treatment for it. Like Lee said, if you do have that blood pressure, then it's probably worth just getting it checked every 5 years if you are over the age of 40 and have any other risk factors for developing hypertension. Now, if you then go into the clinic and you have a blood pressure of between 140/90, so anything above that, and anything below 179/119, then that is classed as stage 2 hypertension, and at that point there will be some investigations that will need to be done, depending on what level it's at. Obviously, if it's at the higher end, it's going to be more invasive in terms of there'll be more tests that we need to do. If it's on the lower end, it might just be that we'll maybe recheck, or but we will go on to that. And then anything above 180/120 would be classed as severe hypertension, and in those cases it's usually a referral to a secondary care setting such as a hospital, so maybe A&E or something like that, for again more invasive tests to see why it is that high. If we go back onto the clinic blood pressure of, like we say, above 140/90 and below 179/119, in those patients we would tend to offer ambulatory blood pressure monitoring. So that is where you usually go home with a blood pressure monitor, and then the readings are taken. How many readings? Is it 2 readings every hour in waking hours, and then you need at least 14 readings on average. Now, it's important to note that with the ambulatory blood pressure monitoring, like I said, it's 2 readings per hour, but only in waking hours. So usually your blood pressure will drop at night. So that's just a normal physiological change that happens. However, some patients who we call non-dippers don't get a blood pressure drop within the night time. If we have a patient who doesn't drop the blood pressure at night, they are at an increased risk of having a cardiovascular event compared to somebody who would dip the blood pressure at night time. So, there's a flaw in that system there where they're not getting checked.
Yeah, that's why we advise 24-hour is the gold standard.
Yeah.
But yeah, like you said, a lot of people do dip at night time, but then there's non-dippers and then there's reverse dippers where actually their blood pressure goes up in the night, and they believe that these non-dippers and reverse dippers have a higher cardiovascular risk overall than if you were to do it in the day.
Yeah. So that's probably important to note. The other thing that you can do is also just do home blood pressure monitoring. Now, you will actually have different targets for home blood pressure monitoring, so Lee can explain them in a minute. But with that one, it would be 2 readings twice a day for at least 4 days. But we usually say 7 days would be, the optimal. And we do say to disregard the first day's readings and then average all of the other readings. The second thing that we'd want to do as well would be to do some bloods. Now, we tend to do this with a lot of patients anyway, just if you've got a new condition, and it's just to check baseline blood. So in terms of patients who've got a high blood pressure, or you've been shown to have a high blood pressure, we also do want to then test for things like end organ damage. So that can be things like damage to your kidneys. So we'll do some kidney function tests. We do fundoscopy, which is it's just to test if there's any damage done to your eyes. Sometimes, we're supposed to do an ECG.
That does happen.
It is the gold standard, and that's supposed to happen, but it is happening more and more now, like you say. And then we'll do a urine, and again, that's to just determine whether there's any damage to your kidneys. So
I feel as though a lot of nurse practitioners who are prescribers do a lot of this more than other professionals, if I'm being honest. Yeah,
I think it's just, the ECG thing, I just know from my personal experience, I didn't even realise that it was, it was something that you had to do until about 2 years ago, I think. Obviously, I'm not a prescriber at the moment, so it wouldn't be something that I'd need to do. But yeah, it was only that when we were doing our CPP course, which is the primary care pathway course, that I realised that you needed to do it. But obviously, like you say, it doesn't always get done, but it is something that we do need to, we should do. And then the last thing that we would do for a patient who has just had a high blood pressure reading, we would assess their cardiovascular risk. So we use a tool called Q-Risk, and that's basically to assess a person's risk. I think we've discussed this actually in a previous podcast, but it's to discuss a person's risk over the next 10 years of having a heart attack or a stroke or some other kind of cardiovascular event. So Lee, do you want to explain when I was saying before about the difference in the home blood pressure readings compared to the clinic?
Yeah, so like you would expect, you are more relaxed at home than in any clinic setting. So for a home blood pressure reading, you're normally aiming for less than 135/85. But when we discussed before about the 140/90 being the cutoff, that's only for people less than 80 years old. Now, if you are 80 years old and above, we do relax that target to 150/90. The reasons are, well, mainly due to having a low blood pressure didn't lead to any beneficial outcomes. And once you get over 80, you're at a higher risk of having falls with the medication. And, without being blunt, you are towards the latter end of your life. So is having tight blood pressure control that beneficial at that age? Mm-hmm. But yeah, like I said, as in all medicine, it's not that simple as an age. There are other reasons for having different targets. So yeah, 135/85 if you're under 80 at home, and it's 145/85 if you're 80 and greater in age. Now, I don't know whether you've looked at all the other targets, such as if you've got chronic kidney disease.
That's what I was just about to say.
So yeah, I mean, a lot of these conditions, so it used to be diabetes, kidney disease, etc., used to have different targets and used to be more sort of lower. So it used to be like the 130/80 for tighter control. Now, in the chronic kidney disease patients, for example, that's based upon how much protein is lost from your urine. So this is something called your albumin creatinine ratio, so ACR. Now, if there's a few people out there that might be kidney patients, so if it's less than 70, you've got the normal 140/90 in a clinic setting, and if it's greater than 70, it then means we need to tightly control it to 130/80 within a clinic setting.
I feel like really for the purpose of like the podcast, it's just kind of being aware that, there is a difference in clinic blood pressure to home blood pressure. So that goes for both health professionals and patients to be aware of. And yet, depending on how the category that you fall into will depend on what treatment options. And like I say, if it is anything above 180/120, it's usually just a straight referral. And then anyone who falls in between that would then need the criteria that we've just discussed, so the bloods, any other tests, the home blood pressure readings or the ambulatory blood pressure, and then also a Q risk. So I think just one more thing to maybe point out is that other things to consider, if you've got a patient who's below the age of 40 who's come in with hypertension, then that would be something where it's like kind of a red flag to refer, because you need to find out the cause of hypertension really. So it could be something like
You're thinking of Conn's syndrome?
Yeah, Conn's syndrome. So it could be something like that. Also, if you think that a secondary hypertension is suspected, then that would also be a referral. People who are on step 4 therapy, which we will go through now, and are unresponsive to it, that would also be a referral to a secondary care setting. Yeah.
I think there's one thing I want to touch upon is that even though blood pressure on paper is a pretty standard thing, it looks easy. If the number's above this, we treat it. Yeah. But in reality, for example, if you've got 140/90 is your target, you could have a patient who's 137/94.
Yeah.
Again, what you treat, a lot of people say you would treat it because the bottom number, which we haven't been through actually, what the top and bottom number mean. So the top number is when the heart contracts, and the bottom number is when the heart's relaxing and filling up. And that's like your baseline pressure anyway within your arteries. But yeah, I mean, in terms of, I think it's the most subjective area in medicine.
Yeah.
Because even if a patient's on blood pressure tablets and technically they should be increased, you tend to get patients going, well, I don't want to increase it, I'll just do my blood pressure over a week, see where it's at, I'll stop doing this, I'll exercise more.
Yeah.
So I think it's the biggest grey area in medicine because, like we said, you don't ever see the benefits of it, only on a reading. You don't feel better when you've got your blood pressure well controlled, unless it's severe and then you're getting nosebleeds, headaches, etc.
Yeah.
So this is leading into the treatment, which is complicated.
Yeah, it's more complicated than what it was when we were first at university.
So when we were in university, it was the simple, if you're 55 and below, it's an ACE inhibitor, which is basically ramipril.
Yeah.
And if you're 55 and above, it was a calcium channel blocker.
Yeah.
But now it's gone completely different. I don't know whether you want to go through the hierarchy.
Yeah, that's fine. So I think, like I was just going to say as well, just before I started to do that, is that that's why it's important to kind of, if you have got a patient who's on the cusp of needing a medication, it's important to consider it case by case and make sure that you make a decision with the patient, because you might get a patient who's quite fit and healthy, who's on the borderline, who thinks actually I don't really want a medication, so you may be less inclined to give them a medication, whereas you might have the same patient but maybe they smoke or they're a bit overweight, and you think, well, actually you might benefit because your Q risk is slightly higher. So it is, for them patients, it's definitely something to consider, that it would be a case by case basis. So yeah, treatment, so like we just said, it used to be easy where if you're less than 55, you were on one drug. If you were older than 55, then you were on another. However, it recently changed. So now, if you have type 2 diabetes, that goes above everything else. So regardless of your ethnicity or your age, you will be started on an ACE inhibitor or an ARB. So I actually did read though, if you have type 2 diabetes and you are of a white ethnicity, then an ACE inhibitor would be the first line. If you are African or Afro-Caribbean, then they say an ARB, and that's just because with an ARB you're less likely to develop angioedema, which could be potentially life-threatening. So that's just something to bear in mind, that if you're type 2 diabetic and the African or Afro-Caribbean descent, an ARB would be the best first line treatment for them.
And
but
some examples of ARBs.
So things like candesartan or losartan, so anything with sartan at the end is usually an ARB. And they're very similar to ACE inhibitors in the sense that they work on the same pathway. They just work at different points.
They work on the receptor as opposed to the enzyme.
Yeah.
Yeah.
So yeah, type 2 diabetes, an ACE inhibitor or an ARB if the type 2 diabetes with, the ethnicities that we said. So that is always the first line. Then if a patient doesn't have type 2 diabetes, it then goes on ethnicity. So if you have a patient who is African or Afro-Caribbean ethnicity, then we'd start a calcium channel blocker. So an example of that would be amlodipine. Then after that would come age. So if you've got a patient who doesn't have type 2 diabetes, they're not African or Afro-Caribbean ethnicity, then it depends on their age then. So it just goes back to, if they're less than 55, then you would start an ACE inhibitor or an ARB if the ACE was not tolerated. And then if they're above 55, then it's usually a calcium channel blocker.
Yeah, and going back to the ethnicities, the reason why we use a calcium channel blocker such as amlodipine, felodipine, is that they found out that in this group, in this cohort, that cardiovascular outcomes were better responded to with a calcium channel blocker in response to an ACE inhibitor such as ramipril. That was the main reason. And then, like you said, it was the angioedema risk.
Yeah. So yeah, that's the first line for anybody, who's newly been diagnosed with hypertension. So you started the patient on the said medication and the blood pressure readings are still coming back as high. Then it's thinking about, you have to then add in a second agent. So at that point,
like with all medicine and all guidelines, is you normally add something in that you've not included from the other first line agents. So if you've been put on a calcium channel blocker, you'll be put on ramipril or losartan if you can't tolerate that, for example. Then there's the third line, which again, you're adding something else which is not being included. And hypertension goes all the way up to the fourth line, which, once you've used these other agents, water tablets, indapamide is previous to that.
Yeah.
And if you've got heart failure, you would have been started on that,
yeah,
because you're normally on a beta blocker and ACE anyway.
Yeah.
And then fourth line, you go to specialist medication, then, which is the spironolactone.
Yeah. So this is, like I said, if you have a patient who then doesn't respond to fourth line treatments, that will then warrant a referral. Just important to note that if you are starting a patient on spironolactone, it can increase your potassium. So you just need to make sure that you're checking kidney function tests really before. But if a patient is being treated for hypertension, if they're on fourth line medications with something like spironolactone, ideally they would have already been on an ACE inhibitor or an ARB, so you should be checking the kidney function tests at least every year to every 6 months anyway.
Yeah, that's the main thing. And if you do have a dose change with ramipril, losartan, etc., it's normally after 2 weeks that you would get your kidneys rechecked. Now, there was one thing that I wanted to touch upon with ramipril, with the coughs, the dry cough. Mm-hmm. Now, it normally happens, I think it's about 10-15% of patients. Do you want to go through the mechanism?
To be honest with you, I knew it when I was at university, but I didn't even look at it this time. I know that it's something to do with bradykinin.
That's it, yeah. So with ramipril, they think that the angiotensin converting enzyme also degrades bradykinin. So if you block that enzyme, basically you're allowing that to accumulate, which then leads to sensory fibres within your trachea, and then that leads you to having a cough.
Yeah. It's like described as just a dry cough, isn't it?
Yeah, it's a dry, irritating cough.
Yeah.
So that's why if we swap it to losartan, for example, works on the same pathway, but it doesn't allow that accumulation of bradykinin. It goes to the receptor, so that gets broken down. You shouldn't get a cough.
Yeah. On that note, I would just say though, if you do have a cough that lasts longer than, is it 2 weeks or 4 weeks?
3 weeks.
3 weeks, then you should always go to your GP anyway, even if you are taking an ACE inhibitor, because if you're taking an ACE inhibitor, it could be potentially that, and you could just switch it, but also it could be something else that you need investigating. So a cough that lasts longer than 3 weeks warrants an appointment with a GP anyway.
And if they can't find anything with chest x-rays, etc., then you could look at ramipril as a potential cause. Yeah. Now, there was something that we didn't touch upon before, and it was something called postural hypotension, which is a fancy word to say when you stand up from lying down, your blood pressure drops quite low and you feel dizzy, which is natural anyway. You know, you can be a young, healthy adult. If you get up quickly from a chair, it's just like your arteries haven't had time to contract and constrict and get blood back to your brain. But what happens is, if your number on the top drops by more than 20, or the bottom number drops by more than 10 from when you're sitting, and then you're standing for more than a minute, then that's called postural hypotension. And at that point, the idea is that we treat the blood pressure whilst you're standing, and we get that below the numbers.
I think also as well, the risk factors for having a postural drop, so patients who are more increased riskers, patients who are over the age of 80, patients who have type 2 diabetes, and if you have any patients who have actually fallen or have got dizziness symptoms, it's worth checking if they do have postural hypotension.
Yeah, and ironically, the medication that we use to treat blood pressure can cause postural hypotension. So that's sort of a catch-22 really, because one of the treatments for postural hypotension is to make sure that the blood pressure is tightly controlled. So then it's weighing up really.
Yeah.
There's very few and far between patients, but there has been a few that have popped up.
Yeah. And then I think the last thing that we haven't really touched on, but the most important thing probably, is lifestyle interventions. So as with any kind of long-term health condition, there are things that you can do to reduce your risk of it getting any worse, and also like maybe potentially reversing it. So specifically for hypertension or high blood pressure, smoking cessation, so stopping smoking. I mean, it's something that we advocate for anyway nowadays. You know, everyone knows the risks associated with smoking, you know, risks of lung cancer, all different types of cancers. So that would be the first thing. Weight loss is another one. So a 1 kilo weight loss can actually reduce your systolic blood pressure, so your top number, by 1. So, you know, if you lose, say, like 10 kilos, which, you know, some patients, it sounds like a lot, but for some patients, you know, if they are significantly overweight, would not be too much of the body weight, you can drop it by 10, which could be the difference of having high blood pressure to actually being normotensive. And then, just healthy diet. So we have discussed this in a previous podcast, in the ultra-processed foods one, and Mediterranean diet is always the gold standard. You know, foods that are high in saturated fat, but like healthy fat, so things like avocados, olive oil, oily fish, lean meat, vegetables, legumes, fresh fruit and vegetables, things like that. They're the healthiest diets to have, and then also regular physical exercise.
Yeah, and the biggest thing with your diet in terms of high blood pressure is salt and sodium intake, because of how it works chemically. So in the body, sodium, salt we're going to call it, when that moves into anything, it also attracts water. So in high blood pressure, if you've got a lot of salt within your vasculature, you're going to have a lot of water there, which is going to increase your blood pressure. Now, it changes. The NHS say 6 grams of salt a day. WHO, which is the World Health Organization, say about 5 grams a day, which in medication terms is about 2,000 milligrams or 2 grams of sodium, pure sodium. The reason I'm converting it to that will come apparent now.
I was going to say,
is because a lot of medication, when it's in the effervescent or soluble form, it contains a lot of sodium, because that helps it dissolve. Like I said, it's the way it works chemically, it attracts water. So for example, paracetamol has 400 milligrams of sodium in each tablet. So if you have the maximum of 8 a day, that would be 3.2 grams, which would be way over the 2 grams of sodium that's recommended. And then when you're thinking about, I mean, they did do studies about taking regular soluble paracetamol and cardiovascular, and there wasn't enough of a population to sort of drag anything from it.
Yeah.
But in general, if you're thinking about modifying all your risk factors, looking to your medication is one thing. I mean, off topic, but when you look at a lot of medication for children, young children, in the soluble or syrup form, it does contain alcohol.
Yeah.
So they're little things that you don't look at and you just you sort of expect it.
I think there's also drugs that can cause hypertension as well. So medications that you can actually buy over the counter, such as ibuprofen, increases your risk of developing hypertension. Other things like estrogen, so any women who are taking hormone replacement, testosterone's the same. Decongestion, so Sudafed and things like that you can buy over the counter, they can increase your risk of, they can cause hypertension.
I mean, technically the nasal sprays can as well, but normally they don't, but it's the tablet form that we mainly are concerned about.
And then steroids, so anyone on long-term steroids, just again, and it's all just being aware of if you are taking any of them medications long-term and you haven't had your blood pressure checked in a while, it might just be worth booking an appointment. Especially if you're over the age of 40, ideally you should be getting them checked anyway, especially if you're on things like steroids or NSAIDs and also estrogens and testosterone. But sometimes it does just it just gets missed. So that's just another thing to point out.
And one thing I wanted to make people aware of is that when it comes to treatment, it's not just a straight, like we said before, oh, you've got 140/90, we're going to put you on this. There are a lot of discussions, there's a lot of decision aids that are used for prescribers and patients to weigh up what it is. I mean, I might run through one of them we just didn't want to bore you on this podcast, to be honest. But for example, let's say you've got that stage 1 hypertension, which is the 140 to, greater than 140/90. Now, if you're over 60 and that CVD risk, which was the Q risk tool that you discussed before, is lower than 10%, you're unlikely to benefit from medication. So at that point, you're sort of just on surveillance, but instead of every 5 years, it might be every 6 months. Whereas if you've got stage 2 hypertension, which we said before, which is over, 160, give or take, you would just be put straight on medication because you are going to benefit from the medication. And it is such a diverse topic. There's so many things to discuss about it.
Yeah.
The biggest thing is that it is known as a silent killer.
Yeah.
Because, like we keep emphasising, you do not feel the benefits of having a well-controlled blood pressure unless it's too late. You're never going to get a throbbing headache, nosebleeds, etc. or kidney damage until it's way into the high hundreds, even 200s. And it is just something to bear in mind and keep a lookout for.
It is. And I think also, like we said at the beginning, it's not a disease. This is a risk factor for developing a disease. And it's modifiable. So like we said, if you tweak your lifestyle, if you increase your physical activity, if you stop smoking, if you reduce your alcohol intake, all of these things can reduce your blood pressure. And so it is something that you have complete control over, if you do things to help yourself. So I think that's also important to kind of bear in mind.
Yeah, I mean, like you said, there are a few instances where there might be a tumour, for example, where you can't control it because you're releasing too much adrenaline, but we can treat it if you're on the lookout for it. But I mean, off the top of your head now, what complications can arise from high blood pressure?
So we have touched on some of them. So we said increased risk of stroke would be one of them, increased risk of heart attacks, heart failure as well.
Heart failure is a big one.
That's a big one. Kidney disease, we did discuss. Also vascular dementia.
Yeah, that's one. But yeah, heart failure is a big one that not many people draw the link to.
Yeah.
But it is just having constant high pressure within your vasculature just does lead to a lot of things. And going back to the kidney, you said kidney disease. Your kidney is that well sort of adapted to high blood pressure. I think back in uni, I think you can have a low, so this is your top number, I think it can go from 60 to all the way up to 180 and your kidney will work basically with normal function. So that's how adaptive your body is.
Yeah.
And that's why, when people say, oh, why would I do this? I don't feel the benefit or don't see the benefit. Your body is that good at adapting to many health conditions and the pathology of a lot of things that it's its own downfall, really.
Yeah.
Why would you can go out and do all these things and your body will compensate, and it's only later on in life that it will show.
The one thing that we haven't actually discussed either is risk factors for developing high blood pressure.
We didn't. I thought we'd done that at the beginning,
No,
but
we
yeah,
didn't.
go on. Let's go through them.
Off the top of my head. Oh my goodness.
Well, you've gone through a few of them, haven't you? So you've got poor diet, which is high sodium intake, which is normally from ultra-processed foods, high fat content, which then leads to obesity, lack of physical activity. Risk factors, I mean, if you've got pre-existing heart conditions or you've got some sort of abnormal tumour. Yeah. Again.
Smoking.
Smoking's a good one.
Yeah. Alcohol
Well, I mean, it's
intake.
not good on it,
No,
it's a good
yeah,
risk
it's good
factor.
risk. Drugs, which we did just discuss, some medications can increase your risk of developing high blood pressure.
So there's alcohol, which could go in under drugs.
Yeah. Age, so we did discuss that. So like
Right,
as you get older,
yeah, your vascular
yeah.
becomes...
So your sex as well. So I think it's more prevalent in women up to 65 have a lower blood pressure than men, but then women tend to have a higher blood pressure over the age of 65. So it's more prevalent in men under the age of 65, and it's more prevalent in women above the age of 65.
What do you think that's to do with?
It's
menopause?
Yeah, probably, because it must be to do with that. Maybe, if they're in menopause, then women are obviously they're more likely to have estrogen replacement, aren't they? So that is one of the drugs that we discussed that can increase your risk of developing hypertension.
Or we have a more relaxed retirement.
Yeah. Ethnicity as well is one. So unfortunately, people of black and black African and black Caribbean origin are more likely to develop hypertension. I think we also had discussed that in a previous podcast.
That was with BMI, and it was
yeah.
Normally white people have a bigger health sort of capacity for diabetes and cardiovascular disease. That's why our BMI can be up to 30, whereas basically every other ethnicity other than white is normally 27.5 for the higher limit.
Anxiety and emotional stress is also another one.
Yeah.
So, it's important to keep your mental health important to take your mental health seriously.
It is.
And then coexisting things like diabetes or kidney disease, and then social deprivation. So in more deprived areas in England, you're 30% more likely to have hypertension.
That's probably linked to the diet, if I'm being honest.
Yeah, a diet and probably different stresses and things.
Of course.
And then the final one is genetic factors. So there was research on twins that suggests that up to 40% of variability in blood pressure may be explained by genetic factors. So a positive family history increases the risk of developing hypertension.
Now, a question before we go is, can you come off your blood pressure treatment?
Yes.
That's to put you on the spot.
Yes. So, like we discussed, there are things that you can be doing to decrease
So let's say you're an overweight person who's got a poor diet, ultra-processed food. Your blood pressure is 150 over 90. You've been put on blood pressure medication, but then you lose, let's say, 3 stone. You then go to a whole food diet. Your blood pressure might go quite low, and then that triggers a review because you've got low blood pressure. And then, like you said, you can come off at a trial without going surveillance. I think the biggest thing is you can trial a lot of patients without medication, but so long as that you are so basically looking after them, making sure they are up to date with all the monitoring. Yeah,
and I think for me, I would just say, just speaking from personal experience with my family, like members, one of my family members was on antihypertensives for years. They were diagnosed in like the 50s. Nothing ever. They always had high blood pressure, and then as they got older and become more frail, lost a lot of weight, the blood pressure naturally then just dropped, and they remained on the blood pressure tablets. To be fair, we're probably not getting the monitoring that they should have been. Was feeling dizzy, and then it was only that I'd said, go to the doctors or go to your pharmacy. Actually, that's where they got it checked. Get your blood pressure checked. And it was found to be low, and so now they don't take any medications now because the blood pressure is completely normal. But I think for patients, especially as they get older, they don't really tend to go to the doctors as much sometimes if they're housebound, and I think that generation as well don't really want to. They don't want to bother anyone. A lot of them are from the war, aren't they? So yeah. But there is a criteria for anyone who is a healthcare professional called the stock criteria, and like you said, as you get older, your body weight tends to decline in a lot of patients. They don't need the blood pressure. We do relax the readings, like we said earlier, because the falls risk. So you could be on medication. It's normally water tablets, benzoyl being the main offender here. Yeah. And they're left on them for ages. They might have had a bit of swelling in the lower legs for years, and it was just never taken off. But yeah, I think if you change your lifestyle, you're more than likely able to come off them. And also, if you do increase in age, there's no point in being on such a strict regime. But like we said at the beginning, it was such a big topic. I think this is the one I was most nervous about because we do it every day. We know so much about it. But when you've looked through the guidance and all these things, there's all tiny little snippets of information that we don't really touch upon. Yeah. This is probably one of those podcasts that we probably will revisit at some point and maybe choose a topic that we've discussed in more detail. But as with every topic in medicine, everything's always constantly changing, constantly evolving. So maybe this time next year, the guidelines for treatment may have changed, and so again we will just revisit things, but yeah, we hope that it's been helpful anyway. It's, you've even found maybe something out during this podcast, or
I think we should try and do a take home for patients or the general public, and then take home for anyone who's like a healthcare professional.
Do you want to do it?
Do you want me to go through it? So for a healthcare professional, I would look at the stop criteria. I would also look at the NICE guidelines, because all the targets have changed with the CKD, and like we haven't even touched upon hypertension in pregnancy, which is a completely different ball game. So all the medications such as Ramipril, for example, they're not used because they can cause harm in pregnancy. You would normally go to all specialist agents such as labetalol or labetalol. Then you've got levodopa. Sorry, not levodopa. Don't do that. Methaldopa. But they're all different. Same with chronic kidney disease. They do have different guidelines. For the public and patients, take-home points are you can do your blood pressure at home, and there's a lot of guidance online on the British Heart Foundation. I just didn't. Well, I was going to include it on like a link.
Yeah, we can include it.
We can do. Yeah. I think the video of one of the ladies she isn't the most enthusiastic.
Oh.
Mind you, it's not the most fun thing to do, take your blood pressure, is it? But yeah, I mean, you can take it at home. The numbers are easy to interpret.
Yeah, I would say hopefully now after this podcast, you could, if you do take your blood pressure, you will be able to interpret what the numbers do mean. Like we say, again, the numbers for you taking it at home would be different to what it would be in a clinic. In a clinic, we do recognise that you will be more stressed, and so the threshold is a bit slightly higher. So yeah, we hope that you would be able to take it at home and be able to interpret the results, and then just know that it is a modifiable factor and risk factor, so you can do things to change the outcome of it. So if you do take your blood pressure and it is high at home, there are things that you can do, possibly within your lifestyle, in order to get your result down. And then obviously, again, for patients, just being mindful of, it is silent and you don't really see you don't tend to get any symptoms of it, but it can increase your risk of a lot of different things. So if you are thinking about, well, should I actually be on medication because is it going to benefit me? Actually, yeah, it will do, especially if your blood pressure is on the higher side. It definitely is worth at least considering, and if not, going for it, because it does increase your risk of quite a number of different things that you may not have been aware before you've listened to this podcast.
Yeah, so I'm going to start by saying thanks for listening. Everything that we've discussed, again, and as always, should not be used as substitutes to seeing a healthcare professional, and it's only for informational purposes only.
Yeah, and if you obviously have any other questions or any questions about this podcast, or any topics that you would like us to discuss in the future, then please drop us a message, and we will, we like reading them, and we will hopefully, we'll speak to you next week.